So in 1995, I brought metformin to the United States single-handedly. At that time, we had insulin and sulfonylureas. So our treatment of diabetic patients was very limited. So when we brought metformin, that was revolutionary. But, compared to today, that was pretty archaic. So today we have phenomenal drugs. The GLP-1, glucagon-like peptide 1 class of drugs are outstanding drugs. They have a huge, huge effect to improve your beta cell function, which is a big problem in diabetics, and they're very, very good at making you lose weight. So the newer drugs, Ozempic, Mounjaro, they can cause up to 15 to 20% body weight loss. So those are phenomenal drugs. The SGLT2 inhibitor class of drugs, which I invented, those are also fantastic drugs because they not only lower your glucose, your A1C, but they provide kidney protection and they provide cardiovascular protection. The GLP-1 receptor agonist drugs as well also provide kidney protection and cardiovascular protection. The third drug I use in my practice is pioglitazone. It's the only true insulin sensitizing drug. A lot of mixed feelings because of the misconceptions about pioglitazone, but in my opinion, it's an excellent drug. It is the only true insulin sensitizing drug. So we treat our diabetic patients with triple combination therapy right from the beginning, and that's a GLP-1 receptor agonist, and it's usually the one that's on the insurance plan that the patient can pay for because those drugs are expensive, an SGLT2 inhibitor, and also pioglitazone. Metformin is a good drug, but actually now it's number 4 on my list of good drugs. But I'm happy if docs use metformin. It's a very good drug. But you're going to have to use these drugs in combination. Now, at the level of the kidney, we need to be thinking about what are the drugs that work on the kidney. And it's a little bit of a different combination here. So we've known for many, many decades that ACEs and ARBs are critical for protecting kidneys. They're also good for protecting you against atherosclerotic cardiovascular complications. So ACEs and ARBs should be used. As I said, SGLT2 inhibitor studies that we and others have done are very, very protective of your kidney. So diabetic patients with kidney disease should also be on an SGLT2 inhibitor. There's a newer class of drugs called non-mineralocorticoid receptor antagonist. Finerenone is one of the drugs in this class. It's a very, very good drug. Patients should also ideally be on this drug. And then more recently, we have a very nice study. It's called the FLOW study, showing that at least one GLP-1 receptor agonist, Ozempic, is very good for protecting kidney disease. So we have 4 good drugs that can help people in terms of preventing diabetic kidney disease. And we need to use these drugs in combination and start them early if we want to slow the progression of diabetic kidney disease. So we really are much better off than in 1995 when we had insulin and sulfonylureas. I mean, when you think back, that was pretty barbaric. And metformin was revolutionary. But now we truly have a revolution with all these newer drugs and many more new ones to come.
And what's your most preferred agent in CGLT inhibitor? Do you have one?
To me, once you block the SGLT2 transporter, you're going to get the same effect with all of these drugs. So I think the best drug is the one that's on the patient's insurance that he hasn't or she doesn't have to pay for. The 2 most popular in the U.S. are dapagliflozin and empagliflozin, and quite frankly, I don't even make the choice. So I just write SGLT2 inhibitor, and when the patient signs out with the ward clerk, she looks at the insurance that the patient has, and whichever drug is on the patient's insurance plan, that's the one that they print out the prescription for. So these are great drugs. I think they're virtually identical, interchangeable. The key is use one of them. Okay, I don't care which one you use, just use one of them.
Is there any of them that are superior in lowering blood pressure or better for blood pressure lowering than the other?
Yes, the SGLT2 inhibitors, the S is for sodium, The GL is for glucose, T is transporter. So you block glucose and sodium reabsorption. So you go into a little bit negative sodium balance, as we've shown. And when you put people into negative salt and water balance, that's good for lowering your blood pressure. So these drugs, the SGLT2 inhibitor drugs, have modest blood pressure lowering. But if you really have hypertensive diabetic patients, they're usually going to require 2 or 3 drugs. One of them is going to be a diuretic. And we have a lot of good drugs for lowering blood pressure. We have, as I said, the ACEs and the ARBs. We have calcium channel blockers, etc. So we do have good medications, but again, treating blood pressure can be difficult in our diabetic patients and usually requires 2, 3, sometimes more drugs to get the blood pressure controlled.
في السابق لما كنت طالب في الطب وفي بدايات تدريبي كطبيب مقيم كان الاستخدام عالي جدا للأدوية مثل السلفوناليوريا والإنسولين. اليوم نادر جدا ما استخدم هذه الأدوية. بالحقيقة يمكن بآخر 7 ل 8 سنوات ما استخدمت في أي مريض من النوع الثاني إنسولين أو سلفوناليوريا رغم آلاف المرضى من السكر اللي أشوفهم، لأنه في خيارات كثير أفضل. فالدكتور ذكر 4 مجموعات رئيسية من الأدوية: محفزات مستقبلات الجي ال بي 1، مخفضات السي جي ال تي 2، بيوغليتازون، والميتفورمين. وحنسمع من الدكتور بالتفصيل عن كل مجموعة وأعراضها الجانبية. وبعد كده بعد ما تكلم عن الأدوية ذكر أهمية الحفاظ على ضغط طبيعي لمرضى السكر، وذكر أدوية منها الإيس والأرابز، وهي أدوية ممتازة للتحكم في الضغط، غير أنها تحمي الكلى خصوصا في مرضى السكر يلي عندهم خطر إصابة بأمراض الكلى عالي بسبب ارتفاع السكر نفسه. وذكر أيضا مجموعة من أدوية أخرى هي النون ستيرويد المينرال كورتيكويد، وأشهر هذه الأدوية الفينيروين، يبطئ تدهور وظيفة الكلى غير أنه يحمي القلب. وذكر أنه يفضل استخدام مخلوط من هذه الأدوية مع بعض لما يكون السكر التراكمي عالي، وطبعا كل حالة حسب تقييمها. وهنا سألته لو أحد جاله تدمير بخلايا البنكرياس اللي هي مسؤولة عن إنتاج الأنسولين، هل مجرد ما تتدمر ما ترجع لوظيفتها الطبيعية ولا ممكن ترجع لوظيفتها الطبيعية؟ خلينا نسمع منه. If someone gets some form of beta cell dysfunction, either pre-diabetic or diabetic, is that reversible, or once the cells get damaged is irreversible?
Oh, no. This, of course, it depends on how long you've had your diabetes for and how long you've been poorly controlled. But the medications we have now are very good at restoring beta cell function. So we did a very large study. It's called the Qatar, QATAR, after Qatar study. And we took people who were very poorly controlled. These were people who had A1Cs 10 or above. They had their disease for 10 to 15 years. And the standard sort of thought before this study was that these people have irreversible beta cell damage. They have to go on insulin therapy. And that's what we normally did to treat these people. But in fact, what we did is half the people we treated with insulin, and the other half people we treated with exenatide, an old-time GLP-1 receptor agonist, and pioglitazone. 3 years later, they had an A1C of 6.1, which is pretty close to normal, and markedly improvement in beta cell function. So, of course, the longer you have your disease, in the longer it takes for you to treat it, if you start to lose beta cells, then the more difficult it is going to get them to come back. But as we showed, even people with advanced beta cell dysfunction, oftentimes you can restore a large part of that beta cell function and get their glucose homeostasis back pretty close to normal.
فزي ما ذكر أنه ممكن استرجاع في حالات كثير وظائف البنكرياس لحالتها الطبيعية وإعادة السكر التراكمي للطبيعي. طبعا كلما تأخر العلاج وكان السكر مرتفع لفترات طويلة، كلما فرص أنه ما يرجع البنكرياس إلى حالته الطبيعية أعلى. وده الكلام بكل الأمراض الأيضية، كلما طالت الفترة زادت المضاعفات. وذكر دراسة اسمها دراسة قطر لأنها تمت في دولة قطر، وحطت لكم الدراسة كسكرين شوت وقتها. وفي هذيك الدراسة استخدموا مجموعة من الأدوية منها الجي ال بي الجيل الأول، يعني أدوية غير المونجارو والوزمبيك، أسوأ من الأدوية الحالية اللي موجودة، مع بيوكليتازون. وزي ما ذكر سكر التراكمي رجع للطبيعي مقارنة بالمرضى اللي كانوا على الأنسولين.